Good afternoon, ladies and gentlemen. Thank you for staying to the latest session of the day. Thank you, Greg, for organizing, first of all, and thank you for giving me this opportunity to give you some updates in implantable and SNS. So what I'm going to do first is going to give you a little bit of an idea about implantables. We'll talk about this topic, and then we will focus more on the SNS as a second topic. So this one doesn't work, definitely, so we go from here. Left one, you said?
Yeah.
Here we go. So what actually are implantable is a very generic word, a very generic definition. So if we look back at implantable, this is anything that we can actually either inject or implant somehow in the inner canal or around the inner canal, try to have that kind of bulking effect over time. And the indication really at the moment is trying to improve those patients who suffer from fecal incontinence, but for a specific kind of fecal incontinence. And I'm saying here passive incontinence, which is given most of the time from an internal inner sphincter defect. So if we're going back to the literature and we look into our experience as well, we find that actually there are only two kinds of injectable bulking agents. We can find either a non-self-expandable prosthesis, so something that we inject and actually doesn't creates more volume, or self-expandable prosthesis, so something that we can inject, and for a reason which I will explain you better later, it will start expanding and creating this kind of volume and bulking effect. So let's have a look at the first kind. We're talking now here non-self-expandable prosthesis. Over the last 20, or I should say perhaps 30 years, we actually saw many brands and many companies coming out in the market with several products. We have the Solesta, which is probably was one of the most common, which is dextranone by Microsteps. We got the Bulkamid, the silicone biomaterial, which is most known as the PTQ, but also porcine collagen, the Durasphere, and as a last, the Nasha, which is probably the most recent one. But yes, all of those basically coming out in the market over the last 20 years, roughly. How do they work? They all work at the same way. Different companies, different materials, but this is the way how those non-self-expandable prostheses work. You have a patient normally either under general anesthesia or under deep sedation. You have a look at the anal canal, do a proper diagnostic, and then you have this syringe which comes together with a kit from the company, and then you inject in the submucosal space the material which was provided. This injection, basically, you inject that material stays there, it solidifies over time, and it creates that kind of a bulking effect which we wish for the patients, trying to improve the incontinence. Now, apologies for the very busy slide, but just to give you an idea, if you look actually for the safety of those products, it seems that all of them, they are quite very safe. All the numbers in terms of complication or adverse events are very low, mostly around the 1%, 1.5%. Only Proctology was noted to be quite higher, about 9%, and only within the first 48 hours. So if you look a little bit in the literature, there are quite several, I'll show you more than dozens of results. All those are pilot studies or randomized controlled trials. Some of those that were coming from here, from St. Mark's. And all of those have something in common. That actually, there is a very poor evidence that those implantable work on the medium and the long term. There are two fantastic and superb systematic reviews, one from 2018 and one signed by Yas, who is here with us. All of them, they're actually struggling to find this long-term evidence. There was lack most of the time in terms of quality of life questionnaires, and only continence scores were taken in consideration most of the time. And the Leo especially said, I cannot really delineate or give you some recommendations on this kind of implantable. So at the moment, really, over time, there is not much of update there. And actually, most of the centers have withdrawn of doing those kind of treatments, even though it has gained, and now I see approvals for most of those brands. What about the self-expandable? We said this is a different kind. This is another kind of prosthesis. If you look at the market and if you look at the literature as well, there are mainly two kinds of self-expandable prosthesis, both branded by THD. The Gatekeeper, which has been overtaken over time by the THD SphinKeeper. Now, not much difference apart from the color of the device if you look there. Actually, there is some differences in terms of the setting up and the procedure in itself. So how does it work? So the self-expandable prosthesis, you have a patient again either under general anesthesia or under deep sedation. You have a look, do your diagnosed bits, and then you use this tool, which is on the left side up. Sorry, this device on the left side up of the screen. You do some radial incision around millimetric incisions around the anus, and then you go with that tool and you deliver those prostheses around the inner canal. So this actually very nice notes from Lita and Solder did a nice paper published on British Journal of Surgery. You see the placement of those skin keepers, so adequate implantation on the left side, inadequate implantation on the right side. Now, you can implant those prostheses in two ways. You can implant those either by digital rectal examination, so your finger will guide the insertion of those prostheses, or you do it by ultrasound scan during the procedure. So you bring with yourself your nice BK instrument. If you have a chance, it's an option in your hospital, you bring with yourself your radiologist, and all together you combine and do this procedure in here. Now, it seems all nice, all fine. Major difference just to say about the skin keeper and gatekeeper. I said the skin keeper has taken over the gatekeeper in terms that now provides more cylinders, more prostheses in terms of numbers, and the volume has changed as well as increased in size. So how does it work? Again, you said we inject those prostheses, which are made by a high expert, and what happens is once the prostheses are in place, in the intersynthetic place, they basically absorb the normal physiologic fluids from the body, and they increase in diameter, they increase in size, and they increase in the volume. And that kind of, once those prostheses have increased in volume, they create the bulking effect that we want over time. But yes, now, if I have to say if it works or not, so I had quite a nice experience with the skin keepers. We collected in this paper, which took all the patients, all the results in a retrospective way from both St. Mark's and another major tertiary center in London, which was the Royal London Hospital, where I was doing a fellowship there. And we had a look at the results of about 36 patients who had the skin keeper injected. Some of them, they had ultrasound scan guided, some others had only digital rectal examination guided. So there was a bit of a pitfall, I have to say. About 30% of those patients, we found them with a prosthesis mislodged in the inner canal. They were all around the place, and we were quite actually surprised, but that's what we found. If you look at those ultrasound scan guided, we got here having looked as a radiologist, you can definitely tell us now, like in the left side, it's actually nicely placed already around the inner canal. But if you look at the right one, you can see actually how misplaced they are. And another surprise was there was a bit of a problem of jamming with the device, which we don't know really if it was our fault or even not where it was coming from. But anyway, seems that sometimes the machine misfires, so not all the prostheses were properly in place. So on the ultrasound scan check 6 months later, we found even a patient who had only one prosthesis in place. Despite all of that, about 50% of the patient actually achieved a very good improvement with nearly 54% of improvement in incontinence. So very difficult here to judge or to say does it work or not. What we know is that about half of the patient had a good benefit, but we had a bit of a lack of confidence in the proof of the mechanism. Perhaps the technique needs to be improved. Perhaps, as we were guided at the beginning, we should have always used the ultrasound scanning for assistance. So if I need to conclude about some bulking agents, I need to say, yes, are definitely safe, both the non-surface self-expandable and the self-expandable. Both very safe either during the procedure, no major complications after the procedures. Definitely are a very good alternative when all the other conservative treatments fail and when we really run out of options. I rather prefer to give patients an option of bulking agents rather than give them a stoma. But there is very poor evidence about the non-self-expandables, especially in the long term. And for what regards the self-expandables, as we say, we need to do much more research, and we need definitely to refine the technique to have a better outcome for our patients. Now, let's talk about SNS. SNS is an acronym for sacral nerve stimulation, which actually, after the European SNS group, has been changed with the SNM, which is actually nowadays the right nomenclature. So what does it do? It directly stimulating either the third or the fourth sacral nerve, and it does it using some currents, electric current, which runs from the battery, which is normally placed underneath the skin in one of the two buttocks. It goes through a lead, and the lead gives this energy, this current on the third or fourth sacral nerve, and it stimulates the muscles around, and we will talk about better later. So at the moment, Sorry, not to look as you should. But anyway, what I meant here is that if you look at the literature again, the sacral nerve modulation at the moment is definitely the first-line surgical treatment for all of those patients who suffer from fecal incontinence, especially mixed fecal incontinence or fecal incontinence, and especially for those patients who has already tried all the conservative measures and they're not at any improvement. So if you look at the last indication, as I was saying, you can find SNM, we should change now, in basically every kind of problems or issues, anatomical issues that we have with the anal sphincter. So even if you have a very major sphincter defect, SNS is still an option. If you look at patients who have a sphincter defect larger, greater than 180 degrees, as we were discussing someone this morning, definitely a sphincteroplasty should be taken first in consideration. Again, there are many variables that we need to consider, and eventually SNS could improve that outcome in the long term. A bit of history about SNM. It's a quite long journey for them, I think. Medtronic came out the first time in 1982, first implants by Tanab and Professor Smith at the University of California in San Francisco. Since then, as I said, a very, very long journey. 95, first implant here, some marks made by Professor Nichols and Caroline Vasey. And again, in 2000, the Medtronic get the CE mark, and finally the SNM started spreading around many tertiary centers. Thousands of patients since then had an implant in place. There are many changes in terms of technology that started from a very bulky devices, difficult to really understand, to set up, to something much easier and straightforward. So we have now implants that they have a nice smartphone, so the patient can bring with themselves, and it's very easier, or very easy, or better, easier for them to set up all the settings and everything. Until the last updates, which I will talk about better later, which regard MRI compatible devices and longer batteries life. Again, if I go back to the future, what happened since 95 when Professor Nichols and Karen did that procedure here? So at some marks. Actually here, it seems that many things happened about SNM and Medtronic. There were many studies made here. They were look at the effects in the physiology. They widened the indications, including the oasis that we discussed before, including the very large and greater sphincter defects. The first one to set up the MDT 301, as we know and as we discussed before, Yas highlighted that as well. MDT is one of the best sources we have nowadays, but not only for us, but for the safety and for the benefit of the patients. So lots of trials coming out from here. How does it work? So I anticipated something before. So what it does is increases the anal canal closure pressures, increase the anorectal angulation. It contracts the levator and external anal sphincter. So all of this muscular contraction help us to improve our incontinence. But this happens together with a different part. This is a different part activated by the SNS when basically the afferent somatic fibers stimulates the sympathetic activation and inhibits the parasympathetic inhibitions. And the combination of those two things bring and leads to the inhibition of the colonic activity and activate the internal anal sphincter. So the combination of everything I told before, the muscular contraction, the inhibition of the colonic activity, the internal anal sphincters, which increases in size, give us the results that we try to achieve for our patients. Right, so if we look at the technique, it looks quite scary now looking at those pictures, but definitely in 95, when Professor Nichols did that procedure, this was the way. We had a patient in a prone position, then they made a very nice, large and wide cut on the sacral promontory, tried to find the sacrum bone, and then tried to find the sacral foramen, go there with the tiny leads, put the leads inside and implant the SNS. But a lot of changes happened since 1995, and slowly the technique changed. Slowly Medtronic came out with something better. They improved the technique. They said, let's stop doing open technique. Let's have some percutaneous techniques. They came out with some needles, which helped us basically to do the same kind of implant, but without making a proper cut. And Spinelli came out with this nice paper from Italy, which was actually, if I remember well, a multicentric study, and had a look at the first group of patients who had the percutaneous technique using local anesthesia. And nowadays, still, in many centers, especially in the US, they're still doing, especially the first trial of SNM in local anesthesia. So last updates, as I said before, was a long way, about three decades of S&M. What we really had was the main problem that we all noticed over the last 10, 15 years was the fact that the battery life didn't last long. About 5-7 years, we were lacking at the low voltage. After 5 years, what happens? You need to bring back the patient to your clinic, rebook them for theater, reopen the wound where the battery was placed, disconnect from the leads, and put a new battery up. So that means more cost, more operation for the patients, and more risk and side effects, and more issues related directly to the SNS. So definitely it was a major problem in that sense. The other problem was that all the S&M implants that we had at that time were not MRI compatible. So there was a problem when patients had other issues, or spinal back issues or anything, that were not MRI compatible, they couldn't get on the MRI. And sometimes we found ourselves, we had to remove, I remember doing some with Yas or with Greg, removing the S&M implants from the patients because they had to go for an MRI. So really, really important thing. So they came out with an option. They came out with the option of having rechargeable and longer battery life. So basically the battery could last long, but the problem here is they were rechargeable batteries, so no batteries that you need to replace. So in this sense, what happened is that you had a kind of different implant. You had a belt to wear up, and you could recharge the battery of the S&Ms like we do with most of our newest iPhone. Very nice idea, but apparently, for what I heard so far, and here are some marks, I think Greg and Karen basically had a greatest number in terms of implants, nearly 40. They had a lot of technical failure, technical faults, so really not that great at the moment. So it needs definitely to be refined. So Interstim X, now this is the latest one. Just spoke to Medtronic the other day. They're coming out. It's already implanted many patients in the US. They're coming with a bit of refined batteries, which should overtake all of those issues and technical failures that we had so far in theaters. And also they stating that the new batteries should last about 15 years if we use those in a very low voltage, which is a really, really, really great news for both patients and surgeons. Let's have a look. SNS, does it work on NOS? Very good question. Well, there are, again, here, there are dozens and dozens of papers. I just highlighted what I think, and I believe are probably the best numbers we can find on the literature. Maida came out with a great paper, 101 patients, about overall success of 56%. Altomare published in the British Journal of Surgery in 2015, that was a multi-centric European study, collected patients from many or most of the countries in Europe. They had 228 patients available for the longest follow-up, which was on a median of 7 years. And there seems to be an overall success rate of about 71%. Again, we had a look here at some marks of our patients. There were initially 256 patients. Unfortunately, we lost some of them on the medium and the long-term follow-up. So if you look at the longest term follow-up, we had a total of 185 patients, with the longest follow-up, which is the longest we can find in the literature as far as I know, which were about 132 months, with the longest patient followed up for nearly 20 years. And we had an overall success rate of about 60%. Now, if you look at the graph, you can see how the continence scores, starting from very high up, it dropped significantly after the implants, it deteriorated even in the medium term, and it's sort of find a sort of a plateau. We can argue a lot about it. Most likely what happens is that we have some issues on following the patients regularly and making sure that the SNS is working in place as they should. Sometimes patients come back to us in clinic only when they got some problems because the incontinence get worse because probably they run out of battery. And we obviously register our scores there. And for us, when we look at the numbers, it seems quite a little bit of drop on the continence scores. So yes, very good paper. Charlie was involved as well, was the European S&M expert group. And again, they simply really highlighted how S&M therapy is actually not that complicated or complex at all. But obviously we need to strictly to do follow-ups in a very strict way for our patients, and we need to adjust the setting in a proper way if we want to have a long-term good effect for our patients. Are there any alternatives in the market out there? Yes, actually there are now. There were not for nearly 3 decades, but more recently, 2019, MedTech came out with a really great news that in the US there was approval, FDA approval for this new system, which was called, and it is called still, Axonics. Axonics is the alternative to the Medtronic. It basically works in the same way. It's got a similar license. You got the same kind of batteries. Probably a little bit more straightforward device. It's not the kind of a smartphone. It just have 2 buttons up and down. Rechargeable batteries, very long lifespan again for their batteries, about 15 years. So this is the greatest news that we had. However, if you look here, Axonics, yes, it's out in the market. We definitely have a few papers stating how this could make things better in terms of cost, in terms of reducing operations for our patients, but we do not have any evidence that this Axonics works as well as the Medtronic, or even better, or even worse. We don't know simply. There is nothing published about the long-term or short-term results for those patients with an Axonics implanted. So in conclusion, definitely S&M remains probably the first-line treatment. Is very safe, is multi-validated over time. You get in the long term about 60% of improvement. There is a bit of, actually I should say, a significant reduction over time, which again, it could improve if we follow up patients more regularly. Medtronic at the moment, with over 3 decades of experience, definitely leads the market. Axonics is definitely an alternative, but we need to have a look at some results. And what we need for the future, obviously, are better batteries and MRI compatible devices, which is the future. Thank you. And again, questions. I think we got another speaker.